I've given two presentations at the meeting here. The first one was about the principles on the importance of cancer stage, about how cancer stage is used by two different groups of people, really. The first is with physicians and the patient interaction in helping determine the prognosis for the cancer and also the appropriate treatment for that patient. But the cancer stage is also very important in cancer control and cancer surveillance activities, so that when we have data on population-based incidence and report that, it's of far more value if you have stage data in conjunction with the incidence and mortality data. Obviously, if you're trying to compare mortality or incidence across various jurisdictions, you may have more cancer deaths in one area than another area, but it may be because the kind of patients are presenting late with a high stage, and unless you have stage data, you don't know what the cause of that is. Similarly, it's useful to have the incidence of the cancer broken down by stage, and you can use that for cancer program planning, for instance. So if you have more stage 4 cancers, you need to invest more in palliative care or expensive chemotherapy regimes, whilst if you have more early stage cancer, then you need to invest in surgery for the treatment of that. So it's useful data for cancer control and cancer planning as well. So it has many uses, not just the initial use, which most people think of cancer stage 4 with the patient-physician interaction, but also on a broader population basis. The talk I also gave included misconceptions in staging, and those are really defining different terms and how people use the wrong terms. So some of them are perhaps people would consider pedantic. So, people talk about the T stage being and the N stage, and they're the incorrect terms. Stage is usually referred to for the stage group, and the proper terms are T category and N category. And talked about the difference between clinical stage and pathological stage, and how certainly when you're looking at the individual patient-physician interaction, you don't mix the two together. But for surveillance purposes, if you don't have full data, you can mix them, but you've got to identify that it's a mixed clinical and pathological stage. And for that, we've introduced a new term, harmonized stage, or H stage. Okay. So stage migration is when a new investigation is introduced, such as a PET scan. If you do PET scans, some patients who before the PET scan were identified as stage 3 will be stage 4, and they'll be early stage 4, so they'll be have a better survival than those who are identified as stage 4 without PET scan, because they'll have more advanced disease. So if you compare two populations, one with a PET scan and one without a PET scan, the survival is better in those who have a PET scan, because you're moving some of the stage 3 patients who did badly because they have metastatic disease into stage 4, but they have low volume metastatic disease, so they do well. So there is an improvement in survival just by introducing a new investigative tool. And stage shift occurs when, if you've got a population of patients, say you've got a population where 20% of patients have metastatic disease, such as in colorectal cancer, and you introduce a screening system, you want to reduce the number of overall patients who have colorectal cancer, but that and survival improves, but that takes time to show. One of the first things you can show is a reduction in the number of patients with stage 4 cancer, and that stage shift. I think it's very difficult to make sure people use the right terminology. It is very important because there have been studies where people have used different staging systems and trying to compare outcome across jurisdictions. And some people have used TNM 5th, 4th, 6th and 7th, and others have used other staging systems. And then to compare them, it's very difficult. So I think the best way is to put educational activities. In the edition of the T&M book, in the introductory chapter, there's always the rules laid out, but most people don't look at those. They go straight to the breast chapter if that's what they're interested in, without reading the introduction. But to try and improve education, we've developed a series of educational tools. One is with collaboration with ecancer. We've developed educational modules, and there's an introductory module that goes over the rules and the terminology. It starts off with an introduction and a pre-test, and then the module itself, and then a post-test. And assuming you do well and pass, then you can get a certificate that you can print. So we have an introductory one. We also have other modules on specific tumor types, such as lip and oral cavity, breast, prostate, colorectal cancer, lung cancer, and cervix cancer. And these are being updated for the current 8th edition. Some didn't need changing, such as colorectal and breast. Prostate is very minor and will be coming out soon. Lung is very complicated and takes some time. We're waiting for the atlas to be revised, and then we will update that. But they're readily available through a link on the UICC website. You have to join the ecancer, but they're free otherwise. And the other thing that we've done is produce some educational videos that they've been written and they're in the process of being made, and they'll be, again, freely available on the UICC website. Other resources that are available on the UICC website is there's a help desk, so if you've got any questions about staging, you can fill out the questionnaire on the help desk, and you'll usually get a response within 48 hours. There's also a list of frequently asked questions that go to the help desk with the appropriate answers for that.